Placenta pathology and pathophysiology. The placenta is one of the most fascinating and vital organs of pregnancy. It is often called the lifeline between the mother and the fetus, as it provides oxygen, nutrients, and hormones while removing waste products. In this video, we will explore the pathology and pathophysiology of the placenta in detail. Normal placenta. General. A temporary organ formed during pregnancy. Functions as the interface between mother and fetus. Expelled after delivery, third stage of labor. Structure. Shape, discoid, flattened, 15-20 cm in diameter. Weight, about 500 grams at term, 1/6 of the baby's weight. Surfaces. Fetal surface, smooth, shiny, covered by amnion, umbilical cord attached here. Maternal surface, rough, reddish, divided into 15-20 lobes, cotyledons. Umbilical cord, normally inserts centrally, contains 2 arteries and 1 vein in Wharton's jelly. Membranes, chorion and amnion enclose the fetus and fluid. Circulation. Maternal blood enters intervillous spaces via spiral arteries. Fetal blood flows through chorionic villi within the placenta. Maternal and fetal blood do not mix directly, exchange occurs by diffusion and transport across villi. Functions. 1. Respiratory, oxygen to fetus, CO removal. 2. Nutrition, transfers glucose, amino acids, fatty acids, electrolytes. 3. Excretory, removes waste products, urea, creatinine. 4. Barrier, protects fetus from some infections and drugs, though not all. 5. Endocrine, produces hormones. HCG, human chorionic gonadotropin. HPL, human placental lactogen. Progesterone. Estrogen. 6. Immunological, provides maternal antibodies, IgG, to fetus. Development. Begins at implantation, day 6-7 post-fertilization. Fully functional by the end of first trimester, 12 weeks. Grows until about 36 weeks, then undergoes maturation and slight aging until term. Normal variations. Cord insertion usually central but may be marginal or eccentric. Thickness 2.5 cm at term. Placenta is usually single, discoid, and complete. Placenta pathology. The placenta is a temporary but vital organ that maintains the connection between the mother and fetus. Any structural or functional abnormality in the placenta can lead to serious consequences for pregnancy. Placental pathology includes a wide range of disorders involving abnormal development, implantation, circulation, inflammation, or tumors. 1. Abnormal implantation disorders. Placenta previa. Definition: placenta implants in the lower uterine segment, partially or completely covering the cervical opening. Features: painless vaginal bleeding in late pregnancy. Risk factors: previous cesarean section, multiparity, uterine surgeries. Placenta accreta spectrum. Placenta accreta, placenta abnormally adheres to the myometrium. Placenta increta, placenta invades the myometrium. Placenta percreta, placenta penetrates through the uterine wall, sometimes into nearby organs. Clinical impact: severe postpartum hemorrhage, often requiring hysterectomy. 2. Abnormal separation. Placental abruption, abruptio placentae. Definition: premature separation of a normally implanted placenta. Features: painful vaginal bleeding, uterine tenderness, fetal distress. Causes/risk factors: hypertension, trauma, smoking, preeclampsia. Complications: maternal hemorrhage, fetal hypoxia, stillbirth. 3 vascular disorders. Placental infarction occurs due to interruption of maternal blood flow to the placenta, leading to ischemic necrosis. Causes: hypertension, preeclampsia, thrombophilia. Effect: intrauterine growth restriction, fetal death in severe cases. Thrombosis and vasculopathy. Seen in maternal diabetes, hypertension, and autoimmune diseases. Leads to decreased placental perfusion and fetal compromise. 4 inflammatory disorders. Chorioamnionitis. Infection of the chorion and amnion, usually from ascending bacterial infection. Associated with fever, uterine tenderness, and preterm labor. Villitis. Inflammation of the placental villi. May be caused by viral, bacterial, or parasitic infections, e.g., syphilis, toxoplasmosis, CMV. Pneumocystis. Inflammation of the umbilical cord, often secondary to chorioamnionitis. 5 developmental and structural abnormalities. Circumvallate placenta, placental margin is folded backward, linked with bleeding and growth restriction. Bilobed placenta, placenta has 2 distinct lobes, increasing risk of retained placenta. Succentariate lobe, extraplacental lobe, can cause retained tissue and postpartum hemorrhage. Velamentous cord insertion, umbilical cord inserts into membranes instead of placental mass, increasing risk of vasa previa and fetal bleeding. 6 tumors and neoplastic disorders. Chorioangioma. Benign vascular tumor of the placenta. Large tumors may cause polyhydramnios, preterm labor, or fetal anemia. Gestational trophoblastic disease, GTD. Includes hydatidiform mole, complete or partial, invasive mole, choriocarcinoma, and placental site trophoblastic tumor. Characterized by abnormal trophoblastic proliferation and elevated HCG. 7 maternal disorders affecting the placenta. Preeclampsia/eclampsia, abnormal placental vascularization causing hypoxia and infarction. Diabetes mellitus, leads to villus immaturity and increased placental size. Chronic hypertension, causes placental infarcts, abruption, and fetal growth restriction. Clinical implications of the placenta. 1. Maternal health. Preeclampsia/eclampsia, abnormal placentation, maternal hypertension, proteinuria, seizures. Placental abruption, premature separation, maternal hemorrhage, shock. Postpartum hemorrhage, PPH, retained placental tissue or placenta accreta spectrum. Placental site trophoblastic tumor/GTD, abnormal trophoblastic proliferation, risk of malignancy. 2. Fetal health. Placental insufficiency, intrauterine growth restriction, IUGR, oligohydramnios. Placenta previa, risk of preterm birth, malpresentation, and delivery complications. Placental infarcts/thrombosis, chronic hypoxia, stillbirth. Infections, chorioamnionitis, villitis, preterm labor, neonatal sepsis. abnormal cord insertion, velamentous, vasa previa, fetal hemorrhage, sudden death if vessels rupture. 3. Endocrine and metabolic effects. Excess HCG, gestational trophoblastic disease, multiple pregnancy, Down syndrome, screening marker. Low HCG/progesterone threatened abortion, ectopic pregnancy. HPL secretion causes maternal insulin resistance, linked to gestational diabetes. 4. Obstetric and neonatal outcomes. Preterm labor infections, abruption, or chorioamnionitis. Macrosomia seen in maternal diabetes due to altered placental nutrient transfer. Stillbirth/perinatal death, severe placental pathology, abruption, previa, insufficiency. 5. Diagnostic and clinical use. Placental examination after delivery gives clues about intrauterine environment and causes of poor outcomes. Ultrasound and Doppler assess placental location, cord insertion, blood flow, and perfusion. Placental pathology studies help explain causes of IUGR, recurrent miscarriage, or unexplained stillbirth. Pathophysiology of placental disorders. Placental pathology generally arises from problems in implantation, vascular supply, or structural abnormalities. Let's break these down. 1. Placental insufficiency. Placental insufficiency occurs when the placenta cannot deliver enough oxygen and nutrients to the fetus. Pathophysiology. This is usually due to abnormal remodeling of the maternal spiral arteries, leading to reduced uteroplacental blood flow. The result is chronic hypoxia and undernutrition of the fetus. Clinical outcomes: intrauterine growth restriction, IUGR, oligohydramnios, preterm birth, and increased risk of stillbirth. 2. Placental abruption, abruptio placentae. This is premature separation of the placenta from the uterine wall before delivery. Pathophysiology: it is caused by bleeding into the decidua basalis, leading to hematoma formation and detachment. Risk factors include hypertension, trauma, smoking, and preeclampsia. Clinical features: painful vaginal bleeding, uterine tenderness, fetal distress, and sometimes maternal shock. Consequences: severe abruption can cause fetal death and maternal hemorrhage. 3. Placenta previa. In placenta previa, the placenta implants in the lower uterine segment, covering or partially covering the cervix. Pathophysiology: abnormal implantation is thought to be linked to prior caesarean sections, uterine surgeries, or multiparity. Clinical features: painless vaginal bleeding in the second or third trimester. Complications: preterm labor, malpresentation, postpartum hemorrhage, and the need for caesarean delivery. 4. Placenta accreta spectrum. This refers to abnormal adherence of the placenta to the uterine wall. Types: placenta accreta, superficial attachment. Placenta increta, invasion into the myometrium. Placenta percreta, invasion through the uterine wall into adjacent organs like the bladder. Pathophysiology: deficiency of decidua basalis leads to abnormal trophoblastic invasion. Clinical outcome: major cause of severe postpartum hemorrhage and maternal morbidity, often requiring hysterectomy. 5. Infections of the placenta, placental inflammation. Infections may involve the placenta itself, velitis, membranes, chorioamnionitis, or umbilical cord, pneumocystis. Pathophysiology: can occur due to ascending bacterial infection from the genital tract or hematogenous spread from the mother. Clinical impact: preterm labor, stillbirth, and neonatal sepsis. 6. Placental infarction and thrombosis. Pathophysiology: interruption of blood supply due to maternal vascular disease, thrombophilia, or preeclampsia. This leads to ischemic necrosis of villi. Clinical outcome: repeated infarctions can cause fetal growth restriction and pregnancy loss. 7. Gestational trophoblastic disease, GTD. A rare but important pathology where trophoblastic tissue proliferates abnormally. Types: hydatidiform mole, complete or partial. Invasive mole. Choriocarcinoma. Pathophysiology: results from genetic abnormalities in fertilization leading to abnormal trophoblast proliferation and high levels of HCG. Clinical features: vaginal bleeding, unusually large uterus,